We start off with the first speaker, Dr. Archana Vare. Dr. Archana Vare is the senior consultant at Arogyam Eye Clinic and Laser Center, Mumbai, and she has a very interesting video for us to see. On to you, Dr. Archana.
Good evening, everyone. So today I'll be speaking about the SICS in iris coloboma. Ma'am, is my screen visible?
Yes.
Okay. So this was a patient who had, this was a 46-year-old patient and male patient with total coloboma. And so decided to do SICS surgery in this patient because this patient had a black cataract. So basic demographic characteristics, preoperative corrected distance, visual acuity, intraocular pressure, along with detailed ocular examination was done for this patient. And the patient underwent anterior as well as posterior segment examination. And the patient had a typical iris coloboma with grade 3 chorioretinal coloboma, sparing the macula according to Idamann's classification. The patient had a hard cataract, almost grade 6 nuclear sclerosis according to the lens opacity classification system 3. The nuclear color was black, and the IOL power was calculated by immersion technique with SRK-T formula. So decided to do this SICS because of the black cataract. Otherwise, the corneal diameter was normal. So after doing the initial tunnel or the initial incision, then I did stained the capsule with trepan blue, and then I did a rhexis. The rhexis imposes a problem in colobomas because many patients have zonular instability or there is zonular loss in some clock hours. But fortunately, my patient did not have any zonular instability, and the corneal diameter was also normal, and the pupil was also well dilated. Then I did the rhexis for this patient, and after doing the rhexis was also not a problem. It went uneventful. It was uneventful. And then I opened the anterior chamber, and after a little hydrodissection and hydrodelineation, I delivered the nucleus. But the nucleus was rocky hard, as you can see now. It was a black nucleus. And that's why I decided to do SICS basically. Otherwise, with such good corneal diameter and well-dilated pupil and stable zonals, I usually prefer to do a phacoemulsification surgery. Then I delivered the nucleus. You can see the black nucleus. And then there was a chorioretinal coloboma behind. And then the remaining cortex was aspirated. And then the IOL was implanted in the back. So the presence of microcornea or non-dilating pupils, absence of zonules or lens coloboma, and the other structural anomalies make cataract surgery more challenging, and they are fraught with complications in these eyes. This patient was like under surgery was uneventful. And the patient did well in the post-operative period also.
I'll call you after this. Okay, after 8:30, I'll call you. Okay.
And patients with coloboma, they develop cataract at a much earlier age as compared to normal population, and they tend to have harder cataracts as compared to the normal population. So this was my post-operative. And that's all. Ma'am, you are mute, ma'am.
These are very challenging cases and you have shown the whole surgery very elegantly. But going on to just elaborating a little more, Dr. Minu, would you tell us, do you have any kind of a cutoff when in a colobomatous eye, you would want in a Brunus and cataract, when you take a call to do a phaco and when would you take a call to do an SICS?
Just today, 2 hours back, I saw one 49-year-old lady with this kind of 2/60 and hand movements in one eye with the choroidal coloboma previously noted. One eye was black, and the other eye was, she didn't have microcornea. We measured. So other eye had a grade 3 to 4 nucleus. So if it is microcornea, and if the nucleus is 3 to 4 towards black color, I would not do a phaco on that, especially when you do not see the lower part of the zonules. Mostly they'll have coloboma there also. In this patient, the black cataract did not have zonules, maybe larger area, actually not just the coloboma area, beyond that also did not have zonules. So it will be difficult for me to do phaco in such kind of black cataract. But till grade 3, and if the pupil we can always manage. You can dilate it with the high-risk hooks and all. So till grade 3, I would do phaco if the microcornea and the chamber is not too very shallow. I would do phaco. But otherwise, if it is too black and if the cornea is microcornea and pupil is pupil, okay, anyway, we can do stretch it with the hooks and then do the rexus and then prolapse in SICS also. So that will be my cutoff. If I'm not comfortable doing, if I think that I'll get a zonal dialysis at the PCN, I would do SICS with a large, not an SICS, I will call it an LICS. It will be a large incision, sutureless, even sutured also. Even if you make a corneal incision, it's better to suture off, put 2 or 3 sutures for such cases, and do a clean SICS in that cases.
But did you see that the trifid blue staining of the vitreous was there? So
I was about to tell that, but I didn't want to comment on the case because I was answering your question.
Yeah.
If you ask me to comment on the case, then all these will come up.
So that means there was some amount of minimal zonular weakness is there in this. That was there. So
yeah, because it will be there, it will be seen.
Dr. Sai, I want to ask you, what would you be cautious about in these kind of eyes, colobomatous eyes, and if there is zonular weakness, would you do anything extra, or would you be cautious of anything extra?
First of all, I think I should
You should increase your volume. Yes, Dr. Sai?
Can you hear me now?
No, it's become very low.
Can you hear me?
On the laptop, can you increase your volume?
Usually Sai is very loud.
Yeah, now it's fine. Yeah.
So I think I should congratulate Dr. Archana for bringing up this case here, because this is in cataract surgery where there's a lot of unpredictability involved.
Mr. Sunil, his volume is very low.
Dr. Sai, on the Zoom window, next to the mute, there is a small arrow. Just click that. In audio settings, the bottom link. Just increase your microphone volume to maximum.
Did you get it?
Next to the mute, there is a small arrow. Click on it. Audio settings, bottom last option. Click on it. It will give a pop-up on the microphone. Just increase your maximum volume to the maximum.
It is already maximum.
It shouldn't have automatically adjust option. Should be unchecked.
Yeah. So I just talk close to your mic.
Yeah, now it is better, sir.
No, that is not. That is me. That is not Sai.
Oh, sorry.
Yes.
Okay, Dr. Sai, let's have your thought.
It's not coming up.
So you can log out once and come back again. That works sometimes.
Okay, in the
Sai,
interim, while Dr. Sai gets his volume increased, Dr. Suven, would you want to comment on this? What question I asked?
Yeah. So 2 things I'm very particular about is I don't want the vitreous to be stained with trypan blue. It not only is messy on the table, and it leaves the patient with a lot of discomfort also later sometimes. So I would plug that coloboma. There invariably there is no doubt that the zonules are deficient in that area inferiorly. So I would like to plug that area with the high molecular viscoelastic to start with before I put the trypan blue. That's something I'll do. And rest, I think I'll agree fully with Meenu that I would rather do a SICS, large incision cataract surgery. And if somebody is not comfortable doing SICS or LICS, I'd rather do an extracapsular cataract extraction in a very hard cataract.
There's also this logic about putting a CTR in these eyes, because besides taking care of that imagined zonular weakness, it also could be a little preventive measure for a fluid misdirection from occurring. Because it stretches the capsular bag. So the fluid misdirection could be a huge challenge, because many of these patients, by the time they come, they have a very hard cataract. A hard cataract and a hard eye can be a huge challenge. So that was one factor which I wanted you all to bring up.
Can you hear me now?
Yes, wonderfully.
Yeah.
Wonderful. Your any thoughts to this before we?
Yeah, no. Before I just was just saying that I should congratulate Dr. Archana for bringing up this case, because this is one of the things in cataract surgery where there's a lot of unpredictability involved.
Yes,
Each case is different. There is no one formula for every coloboma. It depends on whether the zonules are totally absent. What is the amount of lens zonule weakness you have? Sometimes you at the area of the zonule of the weak lens, the rexus may run off. So we usually have alternate things with us. And off late, I had 3 cases in a row where there was rexus is intact, but while trying to do cortical aspiration, the whole bag came out. And I don't know whether any one of you have done this, but I have done 3 cases in a row with iris claw.
Yeah.
With inferior, the inferior part is open, but then these patients are used to that inferior part loss anyway. They don't complain of any visual problems because of that. So I have done even iris claw for 2-3 patients in a row. So these are conditions where you can have right from a simple phaco with maybe plus or minus a CTR with a routine IOL bag implantation, up to what Dr. Archana showed, a routine SICS with the interbag implantation. And in the other extreme, you can have total loss of zonules, and you may have to think of alternate techniques. And microcornea obviously is a big problem. The smaller the eye, the bigger the challenge.
Yeah. The other question is, what are your thoughts about sandwiching the nucleus and the way she brought it out, or would you think of bisecting it, or is just a different technique which each person is comfortable with? Any of you, Dr. Meenu, you want to say anything?
Yeah, I think we should use the technique which you are comfortable with. So if you're not using regularly the sandwiching, I would not suggest in such a huge nucleus into the AC 2 more instruments and pull it out. If she was delivering it with visco, so no vectors also. So larger the incision, you can easily deliver your own way. So that should be the point. The incision should not be tight. It should be loose enough to bring out any nucleus without touching the endothelium. One point which I wanted to make is, when you're injecting trypan blue in these kind of cases or in subluxations, I would rather put sodium hyaluronate on top of the capsule, put a little saline on top of the capsule, and then drop the blue drop by drop on the capsule and paint it. So that we need to go 5.5 millimeters and need not splash the whole anterior chamber with the trypan blue. And also aim, if you're putting under saline or under air bubble, don't aim it towards the lower 6 o'clock location. Aim it upwards so that it doesn't get injected directly into the area of zonular dialysis.
Was it Dr. Siddharth? Somebody raised his hand, wanted to add something. Anybody in the speakers want to add anything? We go on to our next talk.
Yes, madam. I am Dr. Ramlal Sharma.
Ramlal, yes, Ramlal.
Yes. As a rule, I'll say in most of these cases with coloboma, the non-phaco surgery is preferable due to various reasons that was pointed out by different experts. So the phaco will be exception, keeping in all the small. Sometimes the nucleus is pigmented and hard, and even the delivery and the emulsification is really difficult in the small cornea, invariably zonular deficiency and smaller eye. And that will be my comment.
Thank you. Thank you, Dr. Archana. That was a wonderful presentation.